So let's now look at the terminology and nomenclature in cervical, neoplasia, or in the reporting of cervical smears. So if you want to report a cervical smear, so we receive a smear, we take it through the normal processes, stain and cover slip, and we are now ready to write a report or screen and report on that particular case. So to do that, you first need to read the clinical data. So when you sit behind the microscope, you take the slide and the request card. On the request card, remember we mentioned that we just don't need just the name and age. We need the last menstrual period. We need other pertinent clinical, information on there. So when you pick the case, you read you look at the age, LMP, and any relevant clinical history that is provided there. Then you now proceed to evaluate your cellular sample under the microscope. So when you put it under the microscope, what are the things you're going to be looking at? You are going to be looking at what? The background of the cellular smear. So, when you look at the slide under the microscope, you're going to see a lot of cells. And then, of course, the background on of the cells, you may contain or may have microorganisms or things that you would need to report on. So when you are assessing the thing under the microscope, you are looking at the background, and you are also looking at what? The cells that you see themselves. You are assessing the cellular features. So you're going to be looking at the nuclei of the cells, the cytoplasm of the cells, all at the same time. So if you're screening, you're looking at the background, you're looking at the cells, the nucleus, the cytoplasm. And then once you are doing that, you also have to determine sample adequacy, whether the number of cells you are seeing plus the type of cells you are seeing in, renders the sample or the case or the sampling, adequate to be reported on. So you do all that. So it means once you are looking at the thing under the microscope, you are doing the screening and then all that in light of the clinical history that have been provided, which you have already read. Once you are done screening, then you now use appropriate terminology or nomenclature to describe whatever you have seen in the report that you are going to write. And this may involve predicting the underlying histological pattern as accurately as possible, and also making recommendations where, appropriate. So you read clinical history, look at the slide, look at the background, look at the nuclear features, look at the cytoplasm features, determine sample adequacy. Then you can now write the report. But in writing of the report, you're going to be using terminologies that are understood by both the laboratorians and then the clinician. So today we are going to look at the so-called terminologies that we use in reporting cervical smears. Remember, I said that the smear must always be interpreted in light of the clinical information provided. Otherwise, you're going to make an error of judgment. Let me give you an example. Remember, I told you that when we're looking at the normal smears, and we looked at endometrial cells, I said endometrial cells normally should be found in the first 12 days of the menstrual cycle. If you find them at any other time outside this, period, even when they are looking normal, it indicates there's something that must be investigated, because that is not normal. However, if a woman has been fitted with intrauterine contraceptive device, or the IUCD, it's possible to see these endometrial cells any time or during the during the menstrual cycle. So it's possible to see this endometrial cells if the woman is wearing IUCD. But if she's not, then you shouldn't see endometrial cells in your smear outside the first 12 days. So assuming you have a smear, everything seems normal, then you find endometrial cells in the late luteal phase. Based on what you know this is not normal. And you are likely to make a note of it in your report, which will prompt the clinician to, investigate further. But if the clinician includes the fact that that patient is wearing or has been fitted with an intrauterine contraceptive device, then you are not likely to bother yourself with this. So this is just one of, there's so many examples. This should tell you that interpretation of whatever you see must be done in light of what clinical information provided. You don't just ignore the card, the request card, and just go ahead and look at your smear and write your report from what you are seeing without considering the clinical history that has been provided on the request card. If you do so, there's going to be what? Errors in judgment. And this is one of the examples that I just gave you. Okay, so let's go to evaluation of the samples. Of course, it requires great skill. Microscopists must have detailed knowledge of what normal cellular morphology. You should know the normal. That's why we've gone through the cells that you see in the smear or the normal cellular component. Now, for optimal evaluation, you need to state the source of the sample. So it's not all the time that the sample is a cervical smear. Sometimes it's a vaginal smear. Sometimes it's an endocervical smear. For example, if a woman doesn't have a cervix because she's undergone total abdominal hysterectomy due to maybe cervical cancer, they can still take a vaginal vault smear or the vault smear to follow up the woman to be sure that the thing hasn't spread. So if you are looking at the vault smear, that's not from the cervix. You shouldn't expect to see metaplastic cells or endocervical cells as evidence of transformation zone sampling, because this smear is from vagina. So if you don't consider the fact that the smear is from the vagina, you are likely to write in the report that you didn't see transformation zone or the cervical component, or if you are using the old system where we say it is satisfactory but limited, then you are going to say the smear is satisfactory but limited by the absence of transformation zone or in the cervical, component in the smear. So it's important that the source of the sample must be stated, and it's not all the time that the smear will be from the cervical. Method of the collection must also be known. So whether they use the IS spatula, IS spatula, or the cyto brush. Of course, pertinent clinical information must be provided. It's very, very important because screening is always done in light of the clinical information. Now, during the evaluation, you, the one doing the screening or the microscopist, either consciously or unconsciously, will be answering a lot of questions as you screen. So there's so many questions, and these are the possible. You're asking yourself, whilst you're looking at the thing, and you're asking yourself at the same time, is there adequate clinical information on the patient? Is the sample adequate? What is the background like? Are there enough cells to allow confident diagnosis? Where do the cells come from? Is the staining quality good? Are the cells within normal appearance? If not, what cellular abnormality is present? Is there a need for further studies? All these questions will be running through your head whilst we are doing the screening. And to answer these, the microscopic should assess the request form and the background of the smear, as well as the, the epithelial cells themselves. So that is it. Now, clinical information. What information is important? So the minimum information that the doctors or the one requesting the smear should provide is the age of the patient. It's very, very important. The last menstrual cycle, the last menstrual period, which is the LMP, and the cycle must be indicated. We also need pertinent background information. For example, the type of contraceptive, if any, or if you are on hormonal therapy. If you are taking it, you should know, because you see that can affect the types of cells we see. Remember when we looked at hormonal cytology, how the hormones can affect the growth and maturation of the epithelium. So that can also affect the types of cells we see. So if we see any type of cell out of cycle, for example, LMPs 26 days ago, we expect to see a predominantly intermediate cell, pattern, but we are seeing something different. And the request card also doesn't say that, oh, this woman is applying maybe topical estrogen cream for something. Then we see a lot of superficial cells there. That's going to be raise an alarm, like we go, hey, this is not normal. Late luteal phase, and I'm seeing, a lot of mature. But if I know that she's taking or she's applying vaginal, the topical estrogen cream, then I know that, okay, then under this circumstance, that's normal. So if she's had any previous pelvic surgery, it should be indicated. If she's had any pelvic irradiation, for example, there's a tumor in the region and she undergoes radiotherapy. The radiotherapy would direct, radiation to the pelvic, area. Now, this radiation that is directed there due to a certain tumor there can actually cause changes in cells that are found in the cervix, which sometimes can be very weird and can, mimic some of the cells that we see in abnormal situations. So if I don't know that she's had any pelvic irradiation, once I see this, I'm most likely going to say, this is malignant, because we have these very weird, appearances of. If I am aware, then I'll be cautious in saying something like that. So if she's had any previous cancer of the genital tract, we should know. State of the cervix on speculum examination, we should know. So these are the important clinical informations. Experience is important in weighing clinical information. If the sample does not justify a diagnosis, one should not make the diagnosis despite the heavy clinical. Sometimes the clinicians write that there's a lesion on this particular 3 o'clock or whatever of the cervix, and then they write that she's having maybe bleeding, postcoital bleeding, which are all symptoms of cervical cancer. Plus, he told you that he can find a lesion at the cervix during the examination. So you see, all this information already in your mind, this is likely to be a positive case. But you go there and you don't find anything, and you go around, look around, trying so hard to make a diagnosis which goes with what the clinical or the clinician has made. Now, if the sample does not justify that, you shouldn't do that. You shouldn't try and make a diagnosis of a positive case because of the heavy clinical bias or the data, the information provided to you is pointing so much to, that. Now, on the other hand, if the cytological diagnosis is clear-cut and indisputable, heavy clinical bias to the contrary should not prevail. So on the other hand, if you see, a clear-cut, abnormal case that the clinician is not providing anything or making any diagnosis to that, or making the preliminary diagnosis way off from what you are seeing, doesn't mean that you should be silent or try to, make yours tally with them. The cells on the slide are still what matter. Once you've seen it, you've seen it. And we don't throw away the slide. The slides are always there. If there is any, if it can be reviewed, you can always bring the slide back and somebody else can look at it and confirm. So once you can make a clear cut, diagnosis, there's nothing really to worry about, even if the clinician is not, his diagnosis is not, the same as what you have seen. At the end of the day, the cells are there as evidence. So that's what matters. So let's go to the terminology. So we're going to learn some terminologies that are used in what? In the writing of a report. So that when I pick a report, I read, I understand. You understand because the clinician also understands. So what is terminology? It's an organized system of names. That's a very simple, way you can look at it. Now, the use of diagnostic terminology or this organized system of names is used as a framework for communication between laboratory and the clinician. So you write a report in a certain language that you use to communicate to the clinician, which he understands. It can also be used for education purpose. And of course, research, especially when you are classifying, if we have a uniform system of classifying diseases, then it makes it very easy to do research and compare, some of these things from one geographical or one region to the other. But if we are all using different technologies, then it becomes very difficult in research when you are trying to, So terminology also is not static. It evolves as our understanding of the nature of the disease increases. Terminology also may change. And this can also change how patients are managed. Remember a while ago, not a while ago, the class on the HPV, where I had to change the family. I told you HPV was first, classified under the papovavirus family. Now it has changed to papilloma viridae family. So terminology or organized system of names is not static. It changes as we begin to learn more and understand more, or new knowledge comes in. Sometimes we make adjustments to reflect our current understanding of the situation. So this cervical smear reporting all started with Dr. George Papanicolaou. And when it all started, because he was the one that started experimenting these, things, and he came out with numeric system of 5 classes that you use to report. And this reporting system or these classes usually express the likelihood that cancer cells were present in a woman's cervix or not. So we had class 1, class 2, class 3, up to class 5. So if you finish your screening and you report the smear as class 1, what it means is that it's benign. It means that there's nothing to worry about. Class 2 are reserved for smears that have minor cellular abnormalities, but are still considered benign. Minor abnormalities that are considered benign. Then we have class 3 for cells that are suspicious but not diagnostic of cancer. So you see there's some abnormality, this suspicious, but it's not clear cut, like you cannot be so sure that this is. So we put them under class 3 based on Papanicolaou's, numeric, system. Then class 4, that you see cells in the smear that are fairly conclusive for malignancy. And as for class 5, it means that 100% sure cells are diagnostic for cancer. So this is what he came up with at the beginning of, this whole cervical cancer screening, exercise. But there were problems with it. And as we said earlier on, terminology is not static. As we begin to learn more and more and gain more knowledge about disease, these things do change. So Papa Nicolaus classification actually lacked diagnostic precision. One example is that class 2, which was reserved for minor cellular abnormalities which are considered benign, proved inadequate to cover the diversity of what benign reactive processes encountered in what cervical smear. It doesn't provide for diagnosis of non-cancer. You see, we said benign, which are normal, but benign cellular changes, it doesn't provide for example, infections that we see, because infections are non-cancerous lesions. So this is was one of the problems. Also, the groups do not reflect the current understanding of the concept of precancerous. So now we know how HPV infection leads to cervical cancer and the steps that it takes. And the focus of cervical cancer screening is to look for precancerous lesions and not cancerous lesions. If that is the case, if you look at the classes that I just, explained to you, you notice that it doesn't give room for non-cancerous, lesions. The focus is always on cancer. But now we know that cervical cancer screening is used for detection of precancerous lesions. Then we didn't know so much. So at the time that Papa Nicolau, but now we know that this classification, cannot fit our current, understanding and the concept of what, precancerous lesion. So emphasis shifted from determining the certainty of presence of cancer to determining the degree of abnormality of precancer lesions. The precancer is the same as precancerous lesion. So this made Papa Nicolau's classification, this one, obsolete. It's no longer, was no longer relevant to the current focus of what cervical cancer was screening, which is to look for precancerous lesions and not to ascertain the degree of or to predict with certainty the likelihood of having cancer. So this led to several modifications of the classification. So several modifications because some of the classes couldn't accommodate certain diagnoses that we will be seeing. And the modifications from different people actually led to more chaos, because once there's no one standard, everybody is modifying it to suit their situation. There's going to be chaos. It means that when one writes a report from here, another person in a different country may not really understand, because we haven't come out with a standard system. Everybody was just modifying this thing because of its limitations. Okay, so that is what happened in history. So the groups of the Papalucla system do not have an equivalent histological term, preventing the best possible correlation between cellular and tissue. That's another limitation of the Papalucla system. So it means that we had to move away from the Papalucla classification. Then emerged terminologies such as dysplasia and carcinoma in situ. So let's understand what this terminology means. Dysplasia means, you've heard about dysplasia already. It means abnormal growth of tissue. Abnormal, this is abnormal. Plasia means growth. So dysplasia is abnormal growth of tissue. This term was introduced to designate lesions less than cancer and defined as what? a lesion in which part of the thickness of the epithelium is replaced by cells showing varying degrees of atypia. That means varying degrees of abnormality. So now we know we are looking for precancerous lesions. The term dysplasia was then introduced to represent lesions that are less than cancer, meaning precancerous lesions. Then another term called carcinoma in situ means that a lesion of the epithelium in which throughout its thickness there is no differentiation. And I'll explain the two together. At least for dysplasia, you understand. Carcinoma in situ. It's not so different from dysplasia. Carcinoma in situ actually is the severest form of dysplasia. So here, part of the thickness, here the full thickness of the epithelium, showing cells showing abnormal cells or neoplastic cells. Now, but these two names are so different. And if you don't understand what I'm about to explain to you, or these two different names created the impression that these are separate lesions, but in fact they are not. Like I told you, carcinoma in situ is the severest form of dysplasia you can see. They are not different. The term dysplasia and carcinoma in situ creates the impression that these are two different things. They are not different. Only that this is the severest form of dysplasia you can see. Okay, so like I was saying, the implication of this dual terminology that was introduced is that these are separate lesions with different etiology, behavior, and even malignant potential, with CIS being more clinically important. Now, the concept of the continuum of precursor lesions supported by scientific evidence resulted in creation of different categories: mild, moderate, and severe dysplasia, and CIS to reflect the degrees of abnormality rather than the two distinct entities. So the dysplasia has three categories depending on the severity of the dysplastic change. So we have mild, moderate, and severe. And then the severest form of them is the carcinoma in situ. When I'll show you there's an image coming up. Now, behavior of these plastic lesions cannot be predicted. You cannot predict that with accuracy. By this subclassification of mild, moderate, and severe dysplasia, already you would think that, oh, if something is severe, then it is more likely to progress to become cancer than the one that is mild. But prediction of these behavior of these lesions cannot, or we can't actually predict that with accuracy, because some mild lesions would progress. So something that is mild, which based on the definition has the least potential to become cancer, may rather progress. Maybe you might find a moderate dysplasia lesion which would not, or which can even regress. Or you may find that a moderate lesion may become static or remain static, would no longer progress. Meanwhile, someone that has mild would progress all the way to the cancer. So the prediction of whether mild, moderate, or severe would progress to become cancer cannot be done with a high degree of accuracy. Based on the definition also, dysplasia and carcinoma in situ are histological entities, because we said throughout the thickness of an epithelium, meaning we're going to be seeing the tissue, not cells. So they are histological entities, and so can only be diagnosed from histological sections. they do not accurately describe cytological findings because cervical smear is what? Looking at what cells and not looking at the biopsy under the microscope. Another term, so I know for now, you probably are wondering what this mild, moderate, and severe, how there's an image coming up. Or maybe I should just move straight to that place. And so, okay, so now this is a normal stratified squamous epithelium. Look at the basal cells, you see? And then you have from here to somewhere here, you have a parabasal cells because they look round to over. Then from here, you see they change to this polygonal shape. So you're having intermediate cells from here to here. And then maybe this top here, top 2 or 3 lanes would have what we call superficial cells. So this is how the normal epithelium is. Now, if a virus infects the cells at the base, remember, it could lead to low or mild dysplasia. Now look at the mild dysplasia. In mild dysplasia, if you divide the epithelium into 3, so let me use this. So one into 3 equal parts. Okay, so that's it. So 1, 2, 3 equal parts. In mild dysplasia, you see, this is a normal growth pattern. But when HPV comes in and all those other factors also comes in, you will notice that look at this epithelium and see that the cells here look abnormal. Look at how the normal arrangement, look at the nuclei. The cells, they become bigger. Now look at these neoplastic cells. Without here, you can see cytoplasm here. Here you can't even see, they look like nuclei. There's just supposed to be one layer of these cells that can self-replicate here. Look at what's happening here. They have increased in their numbers. Now, when you have an epithelium like this, where undifferentiated neoplastic cells cover up to 1/3, you see 1/3 of the epithelium. If you divide into 3, 1, 2, 3, these cells cover up to here. We call that mild dysplasia. Now, when they cover more than 1/3, but less than 2/3, we say you have a moderate dysplasia. And when they cross the 2/3 line, as soon as they cross this second line into here, then we say you have a severe dysplasia. But in severe dysplasia, you see you still have some small differentiation here. You see here, all these cells, no differentiation. So where you have the undifferentiated neoplasm covering up to 1/3 is mild dysplasia. Where they cross from the mild between that all the way here is called moderate. Once they cross this line, the second line into the 3rd area, then we say it's severe. But with severe, you still see some degree of differentiation. So they cross up to 3rd, not the full. But you see carcinoma in situ. Carcinoma in situ means that you have from the down all the way to the top, you have the whole place replaced by undifferentiated what? Neoplastic cell. That is why I told you that carcinoma in situ is the severest form of this is what? Dysplasia. So you have a mild, moderate, severe, and carcinoma in situ. The full thickness is covered by, undifferentiated what? Neoplastic cell. So do you see why carcinoma in situ is like a continuation? Dysplasia and carcinoma are not different. So carcinoma in situ is the most severe or the severest form of what? Dysplasia you can get. I believe that now this should make sense to you. So you now know dysplasia. So it's for a lesion in which part of the thickness of the epithelium is replaced by cells showing. So you see, this place is a part. So when it is up to the lower 1/3, we say it's mild. If it crosses, then we say it's moderate. If it crosses into the last third, then we say it's what? Severe. If it's a full thickness, then we say it's what? The one here, carcinoma inside. So you see a lesion of the epithelium in which throughout its thickness, no differentiation what takes place. So I believe that now there is confusion being clear. Now, so another term you should be familiar with, dyskaryosis. Dyskaryosis. This term was introduced by Papa Nicola. So based on the term, this is abnormal. Karyo means what? Nucleus. So dyskaryosis means what? Abnormal nucleus. Now, this term, which was introduced by Papa Nicola, was adopted by the Working Party of the British Society for Clinical Cytology. So after going through these small terminologies, we're going to talk about the two main reporting terminologies. We have the BSCC, which is the British Society for Clinical Cytology terminology, and then we have the Bethesda terminology. These are the two we are going to be discussing. So the British people adopted this dyskaryosis term, and this designates cells identified mainly by the appearance of a nucleus, although the cell as a whole may show no significant deviation from their standard normal. So a cell with an abnormal nucleus is what we call a dyskaryotic cell. And dyskaryosis means what? Abnormal nucleus. Now, what constitutes an abnormal nucleus? An abnormal nucleus is one that is what? Disproportionately enlarged. The enlargement is usually at least 2 times the size of normal intermediate cell. Remember, I told you we use the intermediate cell as the reference, nucleus for measuring the size of other nucleus. So if you have a nucleus becoming big or becoming enlarged to the extent that it's about 2x the size of a normal intermediate cell nucleus, and that's not a normal thing. Hyperchromasia. So you have a nucleus staining darker than it's supposed to be, meaning that it's picking up more of the hematoxylin than it's supposed to. We call that what? Hyper. Hyper means high chrome color. So it's highly colored. In this case, it's darkly what? Stained. There's irregular or nuclear outline. So the outline of the nucleus is irregular. There is what? Pleomorphism or anisonucleosis. So meaning different sizes and shapes of what? The nuclei. There is irregular chromatin. So you know how normally the chromatin is supposed to be what? Finely granular and evenly distributed. That can change during cervical carcinogenesis. So you find irregular, granular chromatin. Then you can have multi-nucleation, where you have one cell having more than one nucleus. You might also see abnormal mitotic figures or abnormal nucleoli, but these two are rare normally. So these changes in the nucleus is what constitute an abnormal nucleus. For the cytoplasm may be abundant, resembling superficial, intermediate, or scanty. So you see, after cytoplasm, it just tells us whether we are looking at a mature cell or an immature, cell. The abnormality is always in the nucleus of the cells. So these dyskaryotic cells are thought to arise from areas showing pre-invasive or cancer precursor lesions. It's the same as precancerous lesions. Because you see, in cytology, the brush goes to scrape the top of what? The epithelium, and it's smeared on the glass. So what you will see on the slide is abnormal cells. You're not going to see the abnormal epithelium. You're not going to see the whole of the epithelium. You're only seeing single cells that have been scraped or removed from the abnormal epithelium. So even though we showed you mild dysplasia, moderate dysplasia, and all that, that is histology. And in cytology, we cannot see the whole epithelium to be able to say this is, however, we would look at the type of cells we see in the different grades of the dysplasia, and we can use that to predict the underlying histological, lesion. So that is it. So the dysbiosis can also be graded according to nuclear appearances into mild, moderate, and severe. We can grade dysbiosis just like we can grade dysplasia. But here, the grading is according to what nuclear, but not the level of the epithelium, because we cannot see the whole epithelium. This one is cytology. The other one was what? Histology. Okay. So I think this will be the last term we'll learn before we go to the BSCC terminology. Okay. So another term called cervical intraepithelial lesion, which is the current one, was introduced to remove artificial distinction between dysplasia and what? CIS. You see, now I've told you dysplasia and CIS, they seem to be the same, only that the CIS is the severest form of dysplasia. But having two names seems to suggest that these two are different things. So this CIN terminology was introduced to remove the artificial distinction between this dysplasia and its severest form called carcinoma in situ. So this CIN or cervical intraepithelial neoplasia terminology reflects the basic unity of what? Precancerous. So it means that the precancerous lesions are one with differing degrees of severity, instead of having two different names for the same thing. So this one reflects the basic unity of precancerous changes in the cervical epithelium, regardless of the nature of such epithelial abnormalities. Continuous nature of the epithelial abnormalities finally leading to what? Invasive carcinoma. Problem of biologic behavior still remains, as within the groups, many are not neoplastic, but represent non-specific response to injury from chronic irritation or inflammation. Now, just like we said in the dysplasia or whatever, you cannot predict whether one lesion, which is mild or moderate, will become cancer as against one that is mild. This is the same thing for, since the CIN term is the same as dysplasia and carcinoma in situ, just that it has come to replace it and making all the lesions have one name instead of having dysplasia and carcinoma in situ, but which are basically the same thing. So CIN has come to replace, that. So CIN is graded from 1 to 3. So we have CIN 1, CIN 2, CIN 3. Okay. All right. So to reflect the degree of epithelial abnormality, provided that no prognostic significance is attached to this classification. Implication is that all cases of CIN must be followed up for further evaluation. So let's look at the origin and the localization. So these plastic changes occur significantly more frequently on the anterior rather than the posterior lip of the cervix. I think I've explained a lot of these things during the anatomy and histology lecture. So you can read this part. I'm more interested in the terminologies. So let's look at the thing again. Now the term CIN has come to replace the dysplasia and the carcinoma. Since what? You see carcinoma in situ, dysplasia, mild, moderate, severe, even though the whole thing seems to be one with varying degrees of the abnormality. So look at what CIN has done. For the old mild dysplasia, it is called CIN grade 1. And for the old moderate dysplasia, it's the same as CIN 2. So first, mild is the same as grade 1, moderate is the same as what? Grade 2. But When it comes to severe dysplasia and carcinoma, the CIN grade has put the two together. So once it crosses the third line, whether it is the full thickness or there's still some, everything is called grade 3. So with dysplasia, we had 4 different categories. We have mild, moderate, severe, and carcinoma. With the CIN terminology, we have 1, 2, 3. So it's like severe dysplasia and carcinoma has been put together, has been fused to form one category. That is all. But other than that, you can see that it's still the same thing. So if you know dysplasia and carcinoma, then it's the same thing as what? CIN. So it's just a new change in the name to represent. So now with the CIN terminology, everything, so when you say CIN, then you know that we're referring to these abnormalities, which can be graded 1, 2, or 3, and it's one thing, rather than having dysplasia, which starts from 1, 2, 3, and then the fourth one is not dysplasia, it has a different name called carcinoma inside. I hope, so now let's look at real histology here. It is real histology. So this is, okay, so this is the, okay, so this is tissue, and you can see the normal arrangement, of course, not very normal because you can see coelocytes here. But you can see that, this arrangement here is a bit, look at here. You see that now, so do you see that now? Do you see that now? The arrangement of the cells from below to the top seems to be abnormal, because we know how the normal stratified squamous epithelium, there's some polarity, but look at how the arrangement is here. So you can see that this is the dysplastic lesion. But now that there's a new term called CIN, or cervical intraepithelial neoplasia, it means the same thing anyway. So this one is too small for you. So our next thing is to look at the microscopic features of what CIN. So we'll look at the histology, and then we'll look at what? The cytology. So this is CIN1, which is the same as mild dysplasia. So we said that in CIN1, there is a mild or slight disturbance of the regular arrangement of cells. The upper 2/3 of the epithelium show relatively irregular arrangement and contain cells with slightly reduced cytoplasm and increased nuclei. Nuclei usually round to over slight hyperchromasia. Cells in the lower third show irregular arrangement and lack differentiation. So see the lower, the down, up to 1/3, you have CIN1. It's the same as mild dysplasia. So look at it. At least if you from here going to the top, you see that there's some differentiation, even though the cells have slightly enlarged nuclei and they are normal, but at least you see that normal arrangement in terms of increasing cytoplasm as you go to the top. But if you look below, from here to here, you see, you don't see that differentiation. The cells here look like the same up to here. These are neoplastic cells, undifferentiated neoplastic. So they cover up to the lower 1/3. So this is what? Mild dysplasia, or CIN1. Now, if you take a brush and then you scrape here of a woman, you cannot get these abnormal non-neoplastic cells in the smear. You only get to get this top one. So it means that for CIN1 or mild dysplasia, cytologically, even though histologically we know that a third or up to 1/3 of it has undifferentiated neoplastic cells, and there's some differentiation from the beyond the 1/3 all the way to the top. We only see cells from here. So based on what you are seeing, when we collect the pap smear for somebody with CIN1, we are going to see what? Cells with what? Plentiful, clear, translucent cytoplasm with angular border. So you see cells resemble superficial and intermediate because you see here we have some maturity here, and this is what we will see in cytology. We won't see everything. So those cells are usually mature cells. Okay, so mature cells are either superficial or intermediate. But the difference is that you see that still those mature cells, but the nuclei are enlarged. You see the big nuclei. In the normal stratified squamous epithelium, this is not normal. So even though they will still have the cytoplasm of a mature cell, it's the nucleus that will give them away. So nucleus is slightly enlarged, occupying about a third of the total surface area. Nuclear chromatin is finely granular, evenly distributed, and slightly what? Hyperchromatic. So look at it. You see, they are big, they have a mature type cytoplasm. But look at this nucleus, it's enlarged and what? Slightly hyperchromatic, but the chromatin is not, it's still granular and evenly distributed. In these two cells, there you even have multiple nuclei here. This one is a polycyte. Same thing here, CIN1. You see that you can see a large nuclei, but you can see that these are mature cells and slightly hyperchromatic. Look at normal superficial, look at this one. Look at how big the nuclei is. But you can see the chromatin is still normally distributed. It's just that it's slightly darker than it's supposed to be. That is what you see in the smear for somebody who has CIN1. So for CIN2, just like we said, I'll go straight to the image. Oh, this image is not okay. Yeah, this is better. The undifferentiated neoplastic cells, they now increase their area. So the first is 1/3, but now they move all the way beyond the 1/3 to up to 2/3. So differentiation starts from somewhere around here to the top. That's what you see. Unfortunately, here, then there are several nuclei here that are not showing very well. So it's creating the impression that this is some cytoplasm. But so you can see, yeah, from here, it looks like it stops from here. Here you see some small differentiation to the top. So cytologically, if you scrape here, what sort of cells do you expect to see? Now, the size of the abnormal cells are variable. Include large abnormal cells of superficial cell type and smaller intermediate cells and even parabasal cell type. Most cells are round to oval, occasionally spindle cells, elongated, and basal shapes can also be seen. Cytoplasmic staining is cyanophilic, but eosinophilic cells may be seen. Nuclei are enlarged, round to oval, but sometimes elongated or irregularly shaped. Nucleocytoplasmic ratio is increased. So as the abnormality is increasing, the NC ratio will be increasing. So in the CIN1, the cells you see, even though the nuclei are enlarged, the cytoplasm is also plentiful. So the NC ratio is low. But with with CIN2, the cells would have what? Less cytoplasm. So the NC ratio would be, increased. Nuclear chromatin is evenly distributed and slightly to moderately hyperchromatic. So you can see. So look at the CIN2, the cells. See, now we are seeing a mixture of some polygonal and round. Look at the cytoplasm, look at the nucleus. And large, look at how dark is hyperchromatic. And you can see now the chromatin is kind of like becoming, it's evenly distributed, but looking more coarse than before. Then the third one is what? CIN3. So CIN3, as we've already explained, the full, so look at it from the top to the down. There is just some small differentiation just here. But remember that CIN puts both severe and carcinoma in situ together, so it doesn't matter. So this can be severe carcinoma in situ. So you can see from the top to the down. the same type of cells, undifferentiated cells. Meaning that now when you scrape, you're going to get this type of cells in the smear. So we should expect that in cytology, we're now going to be seeing smaller cells, but having a very high NC ratio. So these are all histology, CIN3. Okay, so this is mitosis. This cell is divided into two. You can see one going here, one is going here. For those that haven't seen mitosis before. So cytology of cells comparable to that of parabasal cells. Cytoplasm is scanty, typically forming a small rim around the nucleus. In keratinizing lesions, cytoplasm often orangophilic and plentiful. Cells are often round to oval, irregular or elongated, and may lie singly or in aggregate. Nucleus occupies at least 2/3 of the total cell area. There's nuclear hyperchromasia, irregularly distributed, coarse granular chromatin. Some cells show extreme irregularity in shape and what size. Large basal shaped cells. So look at this. You see now we are not seeing mature cells anymore. In CIN3, look at the nuclear membrane. Look at the stain is darker, and then membrane is not smooth. You can see wrinkling here, and the cells are smaller. So these ones have even a much higher NC ratio than what you see in what the CIN2. So these are cells you see. So now that we've seen CIN1, CIN2, maybe we'll continue next time talking about the two classification systems.